Hello, Catholic Charities Network. Thank you guys for joining today. I'm Ben Wortham with Catholic Charities USA, here with Kathy Komara and Lorraine Bell, and we are part of the health team here at Catholic Charities USA. Super excited to have Don Kinder from Catholic Charities Eastern Washington. I'm just going to go, before I hand it off to Don, I'm going to go through just a couple slides real quick and talk about the continuing education credit, which I'll then talk about at the end really quick as well. So this webinar is going to be recorded, and you will all get a recording. Everyone right now is muted on computer speakers as well. If Don finishes before the hour, we'll go into question and answer. So there's a couple ways you can ask a question. You can either raise your hand. You have a toolbar on the right side, and you can click you can click the button with the little hand, and that'll alert us, and we can unmute you, and you can talk into the mic and go live. Or you can use the little question bar at the bottom to ask a question. Any questions that are asked and don't get addressed, we can follow up with an email response to those questions. So this webinar over the next hour offers one continuing education credit for you all. How it's going to work is we are experimenting with the handout feature. We're brand new to this, but I think it should be good. If you see the toolbar on the right side, there's a handout that says 205. And in that, you not only have a copy of the slides, but you also have 10 post-test questions that you'll see that's just in a PDF, so you can look at the questions as you go through. Now, those 10 questions, probably by Wednesday, if not Monday or Tuesday, you'll be receiving an email with these exact questions in a SurveyMonkey link from Fanny Cruz email from CatholicCharitiesUSA.org. And I'll say that again at the way end, but just know you have the questions with you, and you get a link 48 hours after the webinar and Monday or Tuesday. So on our webinar now, that's the housekeeping, we have Don Kinder with Catholic Charities Eastern Washington. Don has a master's in social work and a Bachelor of Arts in Human Development. Don is also a mental health professional and has certifications in family studies and violence prevention. After 8 years in workforce development, Don transitioned to government work, leading 8 departments for the city of Spokane, including the community, housing, and human service departments, which allocates millions of dollars per year to partners serving Spokane's low-income and homeless residents. Currently, Don serves as Vice President of Stabilization Services at Catholic Charities of Eastern Washington, overseeing multiple programs focusing on whole person, whole family, recovery, and stabilization. So we're super happy to have Don here with us, and Don, take it away.
Great, well, thank you. So, oh, hold on.
Yeah, let's see if we're going to try to give you access to control the slides.
Let me get right to the beginning here. All right, is that up for everybody?
Yep, that's good for us.
Awesome. Well, thank you guys so much for having me today. As Ben said, my name is Don Kinder, and I'm with Catholic Charities out of Eastern Washington. As you might know, we are a Spokane-based organization, but we do serve 13 counties. And our region is particularly interesting, as many of yours probably is, in the sense that we have a very urban hub here in the Spokane County region. But we do serve a very rural population as well from around Eastern Washington and the Idaho Panhandle. So thanks so much for coming online today. I'm excited to talk with you about this topic and the work that we've been doing to really provide whole person, whole family care for those that we serve at Catholic Charities in Spokane. I wanted to spend just a minute before we review the agenda talking a little bit about how we as an agency think about healthcare integration. There's so many different ways to look at this, and I know we're all trying to figure out how our agency is going to tackle it. So I wanted to explain where we landed as an organizational philosophy. We're really, the mission of Catholic Charities Eastern Washington is really about long-term generational change and ending that cycle of poverty and neglect and all those other complicating factors. So We're really looking at system-wide impacts that change the trajectory of the crisis for generations of people. And we've learned that to best do that, we really have to start at the top with a trauma-informed approach. So we're going to spend some time today really talking about what that means and what we've done here to embed that as a cultural component of the agency. And then we really switched from thinking that we had to provide our own healthcare services to thinking of our housing and services delivery as also a healthcare delivery system. On that premise, we really think about that as a whole person, whole family care model. So it's essential that we're really serving the entire family and the entire person. And when we do that, it really leads to stronger outcomes, both for the individuals and families we serve, but also for our community and region. And that's really how we get to that long-term systems impact and changing that trajectory. I will apologize just for 1 second here. I meant to say it earlier, but I have a 4-year-old who's home with a concussion today. So if you hear a little bit of background noise on my end, I apologize. I'm doing my best to bribe her with candy and movies. So to review the agenda just briefly for you all, we are going to talk about what the trauma-informed approach means, the intersection of trauma-informed approach and healthcare integration, and really how, in our mind, it's one package deal. We're going to walk through an agency assessment that we've completed on the entirety of our agency, as well as some pilot programs to help us rethink how we deliver healthcare integration, and then really look at a couple specific programs here that we're implementing to really tackle that whole person, whole family care from a trauma-informed approach. So stress, everybody's favorite subject on a Friday. I think the big piece here that we're trying to illustrate is that we all experience stress throughout our lives, and we tend to often think about stress and trauma as separate experiences. And in the trauma-informed approach, we're really looking at those as one and the same, especially when we talk about toxic stress. So that positive stress that we all experience on a daily basis, in many cases, are those brief increases in heart rate, a mild elevation in hormones. It might be motivational stress, like you're preparing for a presentation, a good workout, something fun that's coming up, but you have to get ready. Then there's those tolerable stresses that we all experience throughout life. It might be a big deadline at work or an expected loss, but those things are buffered by a supportive relationship, and you know that they're temporary. They're not a prolonged activity. They're painful and difficult, but tolerable. And then that last type of stress is the toxic stress. So we're talking about a prolonged activation of that physiological stress response and the absence of protective relationships. And that toxic stress is in fact trauma. And so we highlight this because it is an important way we shift the conversation that stress is a form of trauma, especially for the clients we serve who are in these prolonged exposures to stress without a protective relationship or end in sight. So when we talk about trauma, we're talking about all of the traditional types of trauma we think about, as well as this type of toxic stress. And we're going to dive into that a little bit as we go through this trauma-informed framework. The trauma-informed framework was really defined and created by SAMHSA, and I know for some of you this might be redundant, but I want to just set the stage for this conversation. The full definition is on top there. The really key points of the definition are in those blue boxes on the bottom of your screen. So we're looking at trauma as either a single event. It can also, and more often in relationship to toxic stress or complex trauma, is multiple events over a period of time. And it is most damaging when it's interpersonal violence or violation, especially at the hands of an authority or trust figure. And when those things happen, there are very long-lasting adverse effects, not only on someone's physical well-being, but also on their mental, spiritual, and emotional well-being. And the trauma-informed approach is really about integrating that full response. So you can see right there out the gate that the trauma-informed approach is really about that healthcare integration lens and how we serve the whole person or family in our care. I use this slide because I think it paints an important picture of the ways that we typically think about trauma in this very kind of nice little box. And really the approach is about broadening that lens and how we talk about trauma. It is a shift, I think, for some people to recognize that we as a service provider do not define what is trauma. The people that we're serving define for themselves what has been traumatic and not traumatic in their lives. For some of us who have had the exact same experience, our reaction to it is different. And how an individual labels that experience and assigns meaning to it is really indicative of whether or not it was personally traumatic for them. So this approach requires that we broaden our lens and the types of things that we think about as traumatic and really allow other people to define for themselves whether or not that event or series of events caused that toxic stress and trauma that they're now experiencing symptoms of. And this is by no means an inclusive list. It's just the things that we most frequently think of when we talk about trauma. So an important part to understanding trauma is what we call neuroscience, and I am not an expert on this, but I have been spending a lot of time in it. The combination of topics here is neuroscience, the ACEs study, which many of you are probably quite familiar with, epigenetics, and resilience. And we're going to spend just a brief amount of time walking through those things because it helps us understand how the people that we're serving are coming to us and how we can best meet those needs from an integrated perspective. So when we think about neurobiology, the key piece here about trauma and toxic stress is that it literally creates changes in our brain's functioning. Now, if any of you recall high school science better than I do, you don't need these notes here, but I am not a science recall expert. So as a quick summary, the two pieces we're really talking about today are the amygdala and that prefrontal cortex. The amygdala is really your emotional computer, that alarm system that creates that fight or flight response. Your prefrontal cortex down there at the bottom is really the protective layer over your amygdala that allows us to make rational decisions, to think before we respond to something, to take in all the information we can, and then make a decision. Your hippocampus and your thalamus are really about our senses and memories, and that helps influence all of our brain's functioning. So I'm going to ask you for just a minute, even though there's a webinar, to take your right hand and put it up in the air. And once you've done that, I want you to hold your thumb in against your palm, and then close all 4 of your fingers down over your thumb. When you do this, you're creating a little miniature brain with your hand. And for those of you who have heard before about flipping the lid, you know what I'm doing here. But ultimately, I want you to think about your thumb as the amygdala of your brain, and your fingers, all 4 of them, as that prefrontal cortex. Now, most of us on the webinar today spend most of our time operating with our prefrontal cortex wrapped nicely around our amygdala. And as we take in information or senses or stress and trauma, we're able to think about it from this rational place, pause and make a decision based on facts and information and thinking about the consequences of that. So a really essential part in being able to navigate day-to-day life. For most of the clients that I serve, and I'm assuming for yours as well, that toxic stress and that continuous exposure to trauma makes it really, really difficult for somebody to walk around with our prefrontal cortex intact because they're operating in a constant fight or flight mode and that survival feeling. So if you can take those 4 fingers that are wrapped around your thumb now and flip them up, that's what flipping your lid looks like. It's when your amygdala is the first thing intercepting information coming into your brain. So your emotional computer is the first thing that you're using to make decisions, inform reactions, gather information and data, and you're not able to rationally determine what to do next or make a response. And we talk about this because this is how many of our clients are coming to access services. And if we're not approaching them as if their amygdala is front and center, we're not going to do very well connecting with them. Now, there's certainly times where you or I have a flipped lid and struggle with that, so you know what that feels like. And I want you to think just for a minute what that would be like if most of your day was spent reacting to things with a fight or flight response because your prefrontal cortex is unable to condense the information into rational and factual pieces based on your exposure to stress and trauma. So that's the neurobiology about how people are often coming to us and they've experienced long-term trauma and now they're seeking whole person integrated care to recover. The next piece is epigenetics, and I'm going to touch briefly on this. There's a wealth of information online about this, but there's a lot of new information coming out about how epigenetics impacts healthcare and the way that it literally alters our DNA. So the studies most recently have really looked at the lasting impacts on American Indian, Alaskan Native populations, survivors of the Rwandan genocide, domestic violence victims and survivors of assault. And what they're really learning is that the way that your genes adapt and your DNA expresses information over time changes based on the trauma that prior generations of your family have experienced. And so you can see that play out in our disproportionate impacts, both in healthcare and in social justice issues. And so this research is really important to thinking about how we prioritize access to care and what we make available for people. The ACEs study, I'm sure most of you are familiar with. I use this slide because of the pieces of information under the roots. So in 2017, a new version of this came out. You still have those adverse childhood experiences across the top. This is, for those of you who aren't familiar, this is a quick screening tool that was established to rate somebody's risk of long-term negative impacts from trauma. The first 10 things that came out were those things up on the leaves of the tree, where somebody as a child exposed to physical or emotional neglect, was anybody in their family incarcerated, have they been homeless, have they struggled with substance use. And then in 2017, a new framework came out that really also took into account those adverse community environments. And how do those community factors also impact ACEs, whether in a positive or negative way, right? Because resiliency is based again on having positive community environments. Typically at this point, I show a TED talk by Dr. Nadine Burke Harrison. I would encourage you to all look at it. It's called How Childhood Trauma Affects Health Across a Lifetime. But really, she's a Surgeon General in California, and she spent years opening clinics for low-income children in the Bay Area of California. What she ultimately found over time was that she was continuing to treat the same medical symptoms for children, but there was no improvement in their condition. And she started looking at the environment because of that and really embedding the ACEs work in her studies. What she found was that patients with 4 or more ACEs were 32.6 times as likely to have a diagnosis of learning and behavioral problems. You think about how we diagnose people and how we treat them based on those issues, you can see really quickly how their trauma is leading to different kinds of medical interventions, but almost in isolation. So we really want to rethink how we treat people based on diagnoses. And then her primary point is just that while it may sound simple, we can't overstate that the most important thing is recognizing what the problem is in the first place. And this is really part of that trauma-informed approach about how do we identify what if people have been experiencing in order to best meet their needs. And then resilience, as you are all familiar, is really just an innate quality that we are all born with. And it's, improved and impacted by things like supportive relationships, positive communication, self-efficacy, and confidence. And that final piece of linear science is really how do we help clients experiencing these traumas with their resilience, growth, and development to help them mitigate the long-term impacts. So we're going to go through some of the trauma-informed approach now, because this is exactly how we informed all of our healthcare integration work. But ultimately, a trauma-informed approach is not about an individual. It's about a program, an organization, or a system that realizes the widespread impact of trauma, understands paths for recovery, recognizes the signs and symptoms of trauma in both clients and families, but also in their staff and others involved with the system, whether it's public safety, healthcare providers, first responders. It responds by fully integrating knowledge about trauma into policies, procedures, and practices. So this is not something we simply train frontline staff to go do, but we have to start at the top and work our way down through the cultural pieces. And then lastly, it seeks to actively resist re-traumatization. We all know, the old adage that clients have to tell their story 15 times, or every time you see a new doctor, you have to repeat your history. That can be re-traumatizing. Environmental factors can be re-traumatizing. So it's really looking at how do we prevent that re-traumatization whenever possible. And then the bottom note there is to help people clarify there's a lot of confusion about trauma-specific services as opposed to the approach. So a trauma-specific service might be motivational interviewing or EMDR therapy. Those are individual interventions we use with people to help them recover from trauma. Those are not cultural organizational structures that help the entire agency approach people from that place of understanding. So the approach is really that cultural organizational piece behind all of the other work that we do, which does include trauma-informed specific interventions. Now, typically, the trauma-informed approach training is a full day training by itself. So I know I'm really dumping some stuff in here, but hopefully we'll have time for questions at the end. I do want to spend a little bit of time talking about why trauma-informed care is important. The first reason is because it's pervasive, and I'm sure as all of you know, trauma is experienced widely. I've got some stats here that I'll throw out because they highlight 2 key factors. Some of these stats are that 60% of children 17 or younger are exposed to violence every year. 10 million children witness violence against their mother annually. 56% of incarcerated men report experiencing physical trauma as a child. Higher ACEs scores are associated with increased tobacco use, respiratory disease, depression, and suicide. And then on the flip side of this, 65% of social workers have at least one symptom of secondary stress. 41% of licensed clinical social workers meet the criteria for PTSD. Immigration judges have burnout levels higher than hospitals or prison wardens. And those are key because our workforce is also exposed to trauma, and how we treat them in this process of whole person care is important. Number two, trauma differentially affects all of us. So there's factors that can make trauma more lifelong, things like an early occurrence, being blamed or shamed, being violated by a trusted figure, but also things like how and where and how often trauma happens. And the key with number two is that it affects us all differently. So something that I might find traumatic and might cause me lifelong health outcomes or impacts might be very different than how somebody else experienced a similar situation. And we have to allow our clients and our employees to define for them what is traumatic and then treat that accordingly, as opposed to defining trauma for them. The third piece is really that flipping the lid analogy around how people approach services, which informs how we deliver services. And then fourth, that our service systems have been re-traumatizing to service users. My favorite quote here is that our clients are having very normal reactions to abnormal situations. If any of us were exposed to the type of toxic stress or trauma that many of our clients experience, we'd behave the same way. Their reaction is not abnormal. Their experience is abnormal. So we need to be asking questions like, what happened? What was your experience? Instead of, what's wrong with you? And then lastly, acknowledging as an agency that healing happens in relationship and with connection. So it can't just be about checking the boxes. It has to be about building meaningful experiences for those we serve as a whole person and with integrated healthcare. So we're going to quickly fly through the trauma-informed approach framework just to give you an idea of where we landed, and then we'll talk really about how we're integrating these pieces on the ground. The trauma-informed approach is really this slide. It's the 3 E's, or what I call the definition of the trauma itself, the event, the experience, and the effect. The 4 R's, or what I think of as the vision, which is that an agency needs to realize, recognize, respond, and resist re-traumatization. The 6 P's are guiding principles of trauma-informed work, which I think of as the mission, which is really around building safety as defined by those we serve, not by ourselves, creating trustworthiness and transparency at every turn possible, and being able to demonstrate that the decisions we're making to build upon trust. Peer support, which we're going to talk about later, but a very specific call out to a specific position your organization should have several of. Collaboration and mutuality. This is really about the balancing of power. So acknowledging that the CEO and your frontline staff are equally able and likely, the frontline staff more likely, to have an impact in someone's daily experience in this world. And so how do we level that power and use that leveling to make more informed decisions about how we decide on policies and procedures? Empowerment, voice, and choice, both for those we serve and for our employees, about how we provide services, what's effective and what's not. And then 6 is really that epigenetics piece. So we have to be willing to identify and acknowledge these cultural and historical and gender impacts from trauma, and really looking at that from a health equity lens. And I'm going to talk more later on about how we're doing some of that very intentional health equity work. And then lastly is the call to action, or the 10 Ds to actually implement the trauma-informed framework. As you read through that list, I think the key things to point out is really around both cross-sector collaboration, meaning that nonprofits have to go outside of themselves and into other industries to build partnerships that actually can create catalytic change. Being willing to think intentionally about how we're training and building our staff to be equipped to both manage the trauma they're experiencing, but also to effectively serve those that they're working with. Thinking about governance and leadership and ensuring that there's opportunities for people we serve to be represented there. And then lastly, to be very willing to invest and evaluate how this work is going. So here's what we did on the ground locally that really spurred this off. Our local healthcare authority provided a funding opportunity to have $50,000 over 5 months to implement and establish an agency approach to trauma-informed care and health outcomes. We were lucky enough to receive that grant late last spring and implement it over the summer. They provided a lot of free training in the TIA framework and best practices. We completed an agency-wide assessment, as well as conducted assessments on specific programs. The tool we use is called the Tricia by ePower & Associates. It's a 4-step tool. It's free online. I'm going to show you a little bit more about it in a minute, but it was very effective in what we were trying to learn about ourselves as we tried to set up this systemic approach and cultural take on integrated health. And then lastly, we mapped those assessments to outcomes and made recommendations for our agency that have literally resulted in new programs being created and new positions being created. So I know this slide means nothing, but what I was hoping to illustrate here was that on the left-hand side, you can see the 5 categories that the Tricia assessment rates your agency in. There's 50 questions that employees answer. We sent this assessment to all 350 or so employees, from our janitorial and maintenance teams to our VPs and everything in between. And we asked them to complete the survey, knowing that some questions didn't make a lot of sense because of the way they were framed. So we wanted everybody's honest response. What you see here is that we have 5 out of our 13 programs that we believe we're already doing some of this work. Those programs are represented as scoring low in those orange boxes. Scoring low means getting a 3 or lower on these questions. Each box represents the question number on the assessment. As an agency, we scored a 3 or lower in any box that's not gray. What we saw immediately by mapping this was that our leadership and culture was strong. Staff believed we wanted to be implementing trauma-informed healthcare integration. They felt like there was space to have that conversation. However, we didn't have policies and procedures or employee skills developed in a way that really empowered people to take that work on, establish those partnerships, and move the work forward. So out of this assessment table, we were able to map some policy recommendations that we've put forward and we're currently working on. The first is really a targeted focus on increased staff training to ensure that both staff are trained and that their supervisors are trained to ensure their fidelity to trauma-informed services and interventions from a healthcare perspective. What we've done so far in our initial big push was we trained over 40 frontline staff over 4 days in very intensive motivational interviewing. And then all of their supervisors received training in person on how to code motivational interviewing tapes so that staff can be taking recordings throughout the year of them doing motivational interviewing with clients, from anything from a peer support role to a vice president role. And then their supervisor can listen back to that recorded tape and provide feedback on how to be more adherent to the motivational interviewing model to make sure that we're really providing that service to clients, but also so that we're really holding staff accountable, and most importantly, being able to effectively coach them on how to improve in that particular intervention. And there's a lot more of that coming. The second big thing was environmental improvement. And I underestimated the power of this when I started this work, but we really have to think about what we're saying to clients in the spaces we serve them in. Like most nonprofits, we rely on a lot of hand-me-down or old furniture, whatever's on the walls is whatever was there 15 years ago. And that doesn't always make clients feel safe and valued and welcomed and warm. And so we really spent about $15,000 improving physical spaces by paint, furniture, wall hanging, sound mitigation systems, lighting improvements, to really help clients feel like the space they were in was a space of value and purpose, and that it was a space they could identify themselves in and feel comfortable in. Another big thing we learned in this, and this is less healthcare based, but also important and very small, was we have several programs to serve previously incarcerated populations, and staff would wear lanyards with keys. But then anytime you're walking down the hallway, there's this jingling key sound, which was re-traumatizing to patients and clients. Their heart rates would spike, their prefrontal cortex would flip, and now we've got people in fight or flight mode because we're jingling keys in their residential spaces. So how do we stop making the keys jingle? So some pretty small pieces, but that really help de-escalate clients and bring them back into a place where they could have rational, meaningful conversation and engage in services with us. And then lastly, the implementation of an agency-wide framework, which we're continuing to work on and roll out. So I say all of that to get us to this point of how we integrate this approach with the healthcare needs that our clients present with. And really locally, here's how we think about this. Our local accountable community of health has a vision. This is the agency managing all of our Medicaid transformation, to integrate community health systems, improving community health through delivering culturally competent, whole person care to all community members. And what we've chosen to do with that at an agency level is to really seek out culturally competent, trauma-informed programming that treats the entire person and does not just provide one piece, which gets back to that, really using our housing and services as a healthcare delivery system instead of just thinking that housing will do the trick, but ultimately with that goal of improving population health outcomes. And we really think about this from the perspective of the social determinants of health. So like I said earlier, when we talk about healthcare, we are of course talking about primary medical care and dental care. We're also talking about mental health, substance misuse services, programming around social service access, parenting, child support, housing, and all of those pieces in a totality make a person whole and healthy. So these are the three key pieces that we have identified that have to exist in a program in order to do whole person integrated healthcare. The first one, and I mentioned this earlier, was utilizing certified peer supports. This is part of SAMHSA's direct call out around doing healthcare integration work, but really utilizing the certified peer supports in a meaningful way. Certified peer supports are not your general floor staff. In our state of Washington, there's a 40-hour week long training that we send staff to. They become officially certified. We can bill Medicaid for those services because they are eligible. And what they're really doing is proving to people that they can rebuild that resiliency, overcome those health and social barriers, and re-engage in this community the way they have always intended to. So certified peer support, if you're not aware, are all people with lived experience personally in either substance use, mental health, incarceration, dependency cases with CPS, homelessness. These are people who have lived the same experience as those we are serving, have come out of it on the other side, and are ready now to re-engage and help those. It provides people with a face and a voice they can actually identify with, and a person who can really coach them in that building of resiliency to help them mitigate for this trauma and toxic stress and take care of those more symptomatic issues like high blood pressure or diabetes. The second piece is client voice and choice. The choice piece being the new item here. We've talked about client voice in the industry for a long time and created feedback loops and councils they can participate on, but that choice piece is really huge. So our next big wave of training coming out for all of our staff who provide services inside of our permanent supportive housing units is around two different models of client choice and how they manage their health care, so that we can actually have a caseworker sit down with a client who's got a chronic health condition, talk with them about the ways they can choose to manage that condition, and then allow that client to drive the conversation and choose to be in control of how that condition is managed and treated. And then our job is to support that process for them and help them manage it so that we don't have it get out of control. Lastly, it's intentional partnerships for equity and access. So Catholic Charities Eastern Washington is never going to be all of the things for this community, but we do have an incredible platform from which to provide services. So we are currently actively seeking and actively engaging with medical professionals, dental providers, and people in our community who add that service we don't have, but they bring it on site to our locations to improve access for populations who we know struggle to go access it someplace else, even if it's one bus ride away. And we focus particularly on health equity and ensuring that those who are overrepresented in these populations have services that meet their individualized or cultural needs. And I'm going to talk more about that. So one program that I had mentioned earlier was our Rising Strong program. This is a program that serves exclusively families engaged in the foster care system. We bought an old convent, we house them in it for 12 months, longer if they need it. The family stays together instead of children entering the foster care system. All of our families come to us because they have a substance use or misuse diagnosis. And then on site within their housing, we provide all of the services you see on that screen. We have primary medical care. We have medication management services. We currently transport for MAT services, so we'll bring it on board. We provide individual, couples, and family therapy, DBT, EMDR, and a variety of other services. They get all of their substance use treatment on site in their housing facility, both intensive outpatient and outpatient. And then we provide all of that social servicing programming as well. So we have certified peer support, case managers, care coordination, and then we do a lot of work with early and parenting learning supports. We currently have 45 children living in that facility. 27 of them are ages 0 to 2. So an example of where we married mental health and social services is that we had a local, one of two, local infant certified therapists designed for us a play group for parents and small children. Our marriage and family therapist facilitates that group with our early learning staff as a part of it. And those parents are then learning those skills together in the room with their children, and they're continually talking about that in their housing facility. All of their peers are going through it with them, and the staff they see 24/7 has participated in that group. So we're really looking at this as how do we address the totality of the primary care, the mental health, the substance use, and the social service piece, all in one roof. And we do a variety of funding strands here for this, but clearly, as you can see, Medicaid is a big portion of how we fund all of these services, but it took multiple providers to do this. Our substance use treatment, as I need to point out, is currently provided by the American Indian Community Center. So Rising Strong is one of our programs that has a very specific health equity lens. We intentionally target American Indian, Alaska Native populations because of their overrepresentation in all of these systems, but in particular in our foster care system. We have a very large tribal population in our rural communities. We set aside 20% of our slots for that population. We currently have 37% of our families who are Alaska Native American Indian. As such, our substance use treatment is all done by the American Indian Community Center, and they bring a very different approach to that healing and recovery. And that staff member of theirs is full-time in my facility and participates in all of our staffing, all of our planning for mental health services, and really helps us take into account that cultural piece. It's certainly not something we've perfected, but we're working really hard on that equity piece and using healthcare as a way to address that cultural sensitivity and ensure we retain people in treatment because it makes sense for them. This program currently, and I'll show you a few photos here. So like I said, we house 35 families at a time. That family C is about to graduate, all in an old convent that we now have fully filled up. And we currently have about an 85% retention and graduation rate in the program compared to about a 60% retention rate in a traditional intensive outpatient. Our foster care cases close, about 80% of them within 6 months, with kids typically being reunified with mom and dad within 6 weeks. As a state, we only average reunifying 57% of kids removed from home over 3 years. So we are bringing kids home much, much faster, reducing that incredible trauma they've experienced. We're treating parents together for substance use and mental health alongside with their children, so they're seeing each other heal and grow. And we take single moms, single dads, or families. So we right now have 7 single dads in our facility. There's no other facility like this. So when we say whole family, whole person care, we really mean it. We cannot make dad healthy by himself and then bring children home 12 to 15 months later and expect long-term success. These kids being with mom and dad, watching them develop and grow is essential to our success. This program also has 33% of its staff with lived experience, either in foster care themselves, substance use, mental health, or incarceration. And we have 30% of our staff who identify as a member of a minority population. This is very intentional. Spokane is predominantly white, so we work really hard to hire people who our families can see themselves in. A couple of catalytic partnerships I just wanted to highlight, particularly to Rising Strong, though we partner with these organizations at many points within our agency. As I mentioned, the American Indian Community Center and Excelsior Wellness Center are very key. We also have a very unique partnership with Head Start, and we have 3 full-time classrooms in the building next to us dedicated exclusively to Catholic Charities families. So we're focusing very heavily on that early learning piece. The Cambia Foundation funds us for trauma-informed work with young children, really targeting early learning, so really bringing that holistic whole person treatment right in at the ground level. Because of that, Excelsior is able to do a lot of medical care with young children. And we just this weekend are happy to announce secured a dental provider who will be providing dental services for our families as well, which we know is key in early childhood health. The last piece I'll mention here before moving on is that the Rising Strong program has a funding grant from the Children's Bureau, which mandates a 5-year cross-site study that we do in partnership with Washington State University. So we have a full-time research person at our site 3 days a week enrolling these families in a cross-site nationwide study looking at interventions for foster care focusing on health. And we're very excited to see what that data says in a couple of years. We just started year 3 of that 5-year pilot. The next 2 things I want to talk about as some additional examples of how we're integrating trauma-informed care and healthcare integration on the ground is a partnership with Providence Healthcare. Providence Healthcare is a very large healthcare provider in our region. And we've got 2 new projects coming online with them, really focusing on impacting health for our clients from a trauma-informed perspective. The first is a mobile health screening pilot that's about to launch. We will have roving integrated healthcare teams visiting patients on site at their home in their permanent supportive housing building There will be an ARNP, a licensed mental health and behavioral health specialist, and dental care, all coming on site to provide services and assessments for clients in our housing projects, including families and singles in permanent supportive housing. They're also all signing MOUs with us to share their recommendations and findings so that we can support those clients in seeing those recommendations for healthcare improvements through, if not with this team ongoing, if they want to get a primary care provider outside of that team. And then lastly, we're going to be able to cross-reference our data with Providence Healthcare and identify if we're actually able to reduce visits to the ED, incidents of public safety or first responders, and start trying to demonstrate how we're really tackling this community issue of healthcare access by bringing it on site and providing people the information they need, along with their care coordinator who can help them see that through. I get confused by what my doctor tells me, and I'm fairly competent. So I can only imagine for somebody with a lot of toxic stress and trauma that trying to navigate how to manage a chronic health condition is quite complicated. So by bringing that together in one integrated team, the permanent care coordinator, we're really hoping this is an amazing improvement. We have a commitment for at least 12 months of that service, and we should be launching here in the next week. The second piece we're doing is targeting a very different population. It's called stable placement. It's capacity building and placement support for adult family home care providers. I don't know about your communities, but our hospitals often have a challenge with long-term stayers. So our adult family homes are typically, mom and like a family home that's taken in an adult for extra income. They'll bring that adult when the behavior outburst happens to the hospital. These are adults who are placed in care because they can't safely take care of themselves, primarily for behavioral health reasons. And so what happens is they might bring them to the hospital for a UTI, but once they have left them at the hospital, they don't come back because of that behavioral impact in their home. So we work with Providence to design a new pilot where we are hiring a full-time therapist and case manager who will be the support system for those adults that the Providence is placing back into adult family home. And we are the on-call service. We create a behavioral intervention plan with the adult home care provider and the adult in care, walk them through that plan, respond to a phone call when something is happening, adapt to that plan, and help provide care coordination for that adult to minimize that adult re-entering the hospital room and to help those adult home care providers feel like their needs are being met and heard as well, with really the intent to both reduce long-term hospital stays, but also to stabilize those adults who are coming in and out of the ED for non-medical reasons. The last two things I wanted to just share with you all that we are working on, or that are actually, these are both already off the ground. One is a contingency management study that we've decided to partner with Washington State University on again. They got funding to do an incentivized alcohol abstinence and reduction program and study. So they are over a 12-month period, 3 days a week, they are in our PSH project, permanent supportive housing projects for singles only. We're not doing it for families yet. They're enrolling those residents, providing assessments, support for alcohol-related medical needs, criminal justice involvement, and some other support services. And as an incentive, each person enrolled in that project provides an on-site, very simple finger blood test prick that can actually identify alcohol intake over the past 30 days. And depending on that reduction or abstinence in alcohol, they're actually receiving cash Visa gifts to help them stay sober and better manage their health. They continue to access all of those services, whether or not they abstain, but it is an attempt to say, if we can get the alcohol intake under control, how much else can we support this person with their medical health or their criminal justice involvement or any other support service needed. So we're working very closely with that team in each of our sites. And then the last thing I'll mention, though it's certainly not the last example of what we're doing up here, is that we are part of what's called the Invest Health Initiative. And this is actually a 50-city initiative sponsored by the Robert Wood Johnson Foundation, started back in 2016. And it's really about connecting sectors for improved health outcomes. So they selected 50 mid-sized cities across the country, which has been an amazing opportunity because we're actually talking to like-sized cities. Often hearing what works in New York City or Seattle does not apply to our world in Spokane. And what we've been able to do is travel a lot to other communities, learn how they are using housing as a healthcare delivery system, and start to replicate that. So based on that work, this travel team there's 6 of us that have been doing this, like I said, since 2016. We have 3 built environment projects all coming online in the next 24 months with an intentional focus on health equity, impact, and integration. One of those is a family housing project that we're building called Gonzaga Haven that will house homeless families or formerly homeless families. Their apartment building is going to include in it Head Start classrooms, medical exam rooms, dental exam rooms, as well as a counseling space and a variety of other services so that we can, again, create this opportunity for them to have all of those needs met in one building. Another example of a built environment project for the Invest Health piece is a new youth shelter we're building with all of the same amenities included in it, as well as a new women's shelter. Those other two projects are both being built by our local Volunteers of America group, but all in coordination and focused on this Invest Health work to really target equity, impact, and integration on site for folks and braiding those funding streams and creating those catalytic partnerships. So really, to just summarize, and then we should have some time for some questions, is that our goal here is to have very intentional impact through healthcare integration by really improving access and equity to address all social determinants of health, which includes that primary medical care, substance use, mental health, but also things like housing and parenting, and how do I connect my child with resources, and how do I meet my nutritional needs, that entire whole person piece, which is really that whole person, whole family care. If we want to create meaningful opportunities for sustained change, we cannot treat one portion of each client we serve. We have to be able to meet the needs of that whole person or family, and we don't need to do it ourselves. We need to do it through meaningful catalytic partnerships that are also focused on population health from a health equity, trauma-informed approach. And then lastly, our big goal is really generational diversion and prevention. We want to put ourselves out of work. We probably never will, but every goal we create should be about changing that trajectory of the crisis over time and not just fixing it for today. The days of Band-Aids are behind us. We have to look at meaningful, sustained change that allows people over generations to disengage from the systems we offer and to help them repair from that trauma that we know is being passed down from generation to generation. So that's kind of the big summary of what we're doing. And really, this is complicated, big work, so we certainly do not have it all figured out, but I feel like we've really found ourselves in a good place culturally and certainly in a region that's open to this level of very deep work in partnership. So that is my presentation, and I am happy to take questions. And as Ben said earlier, I'm also happy to take some questions via email through Ben or directly. My email's on the screen, and help people get any clarity on what I've said so far that would be useful for you all.
All right, cool. Thank you so much, Dawn. So we do see some questions coming in on our end. So what I'll do, Dawn, is read out the questions that come in.
Okay.
We have some hands raised.
Oh, we have some hand raised. So can we unmute it? We're going to try to unmute the people who are raising their hands so you can go live here. I'm going to call out the name.
John.
We got John Pedigo.
Oh, hi. Hi. I was just, we're also working in some trauma-informed work, and we've done some training with people, and it's about 16 hours of training of doing this, doing trauma-informed work with Bridget, who's right now on maternity leave. I just wonder what your thoughts are on training people, and have you used just regular folks to be kind of accompaniment people, to walk with the people in their journey, kind of peer support, but those people that are trained to be peer supporters have been trained through, have been given trauma-informed training, and have you found that to be helpful, or have you thought of that, or what are your thoughts on that?
It's a great question, John. We have been very intentional about getting all of our peer supports trained in trauma-informed care. One thing that we learned early on in the days of peer support was that a lot of our peers have incredible lived experience, and they come from this place of deep understanding. But some of the I don't like to use this word, but some of that more technical nuance is not something that they've necessarily had a lot of exposure to. And so helping them get that training so that they can ensure that they are not accidentally re-traumatizing patients or clients they're working with has been very important, because they are able to have these very frank conversations with clients about use or abuse or homelessness. And it's easy in that space to accidentally re-traumatize somebody or trigger them. And so we found that providing that support to peer support not only has made them feel much more empowered in their work, but it's also helped the client see that turn to resiliency as well.
And just a follow-up question. Having that dimension of peer support, have you seen any kind of is there any data impact study of showing that people have accelerated in their programs of recovery, or that they've achieved their goals in a more effective way through trauma-informed practice?
I'm not familiar with any large study, but that's a great question. I would say anecdotally, in the current round of families we have at Rising Strong, which is probably our most integrated trauma-informed site, 2 of our dads who live with us, who have not even graduated the program yet, have already completed their own certified peer support training to enter this line of work. And they've been living with us for probably 10 months now. And we have certainly seen in our substance use metrics and even our mental health metrics, we're seeing our families progress much faster and more successfully through their own treatment, if you will, and then finding their opportunity in the employment world that's meaningful by doing the same work they've been exposed to. So we're making some assumptions that that's certainly true, but I haven't seen a broad study on that. But it's a great idea if it hasn't happened yet.
Okay.
All right, we're so all the mics right now you are muted, but you can unmute your mic and just hop in with a question if you have one, and we'll give that a couple seconds. We have someone who wrote in a question. Samaya wrote, is the TRESIA assessment available to anyone? Where can we access it?
It is. It's a completely free assessment. Their entire package is online at their website. It was created by ePower and Associates. And all 4 sections are on there, both the introduction to the tool, the history of trauma-informed care, the assessment itself, and then the actual template for agency change. They're all free and online in PDF form.
Thank you. I have a quick one, Don, for you. For Rising Strong with the provider, I know with the providers that you use, do you find that the clients spend a lot of time off campus, or it's a lot of in-house service? Or how much time would they spend with all the services you offer and the partners you partner with a week, or what does that look like?
Yeah, so it's a 3-phase program while they live with us. The 4 phases are aftercare after their alumni. But while they're with us, they're in about 24 hours a week of program time that we provide for them between substance use, mental health. We do 4 certified peer support groups a week that I didn't mention, and then their parenting and therapy classes. We don't mandate individual therapy, but we do mandate things like DBT. So they're in about 24 hours a week of programming. Then the time outside
just
of
right
that,
on campus.
Yeah, they don't leave the building at all for that. And then typically outside of that, they're on site with us, but they're engaging with their caseworker, their peer support, but they do things like grocery store runs. We're not a locks facility.
Gotcha. Anybody else?
One other thing I would throw out there, just so that folks know we're doing it, and I apologize, I don't know why it's not on here, but we also run a respite program in partnership with Providence Healthcare, where they can discharge homeless patients who are no longer medically acute but could not return to a street scenario. We hold 25 separate beds for them at our downtown main shelter, and we actually have nurse practitioners there so that we can get those emergency department beds back online sooner for the community, and then engage those folks with the other services they need to stabilize. And that's been a very exciting and successful healthcare trauma-informed approach practice as well.
Gotcha. All right, well, we're going to wrap this up. I'll just say 2 things real quick. So the first one, again, is if you want the continuing education credit, which I'm sure a lot of you do, please wait. So you have the questions and the handouts on the toolbar. If you click the handouts, you can see the 10 questions. Those 10 questions on Monday, Tuesday, or Wednesday, you're going to get an email from Catholic Charities USA. There's going to be 3 things in the email. There's going to be a YouTube link to this recording. There's going to be the slides to this. And then the third is going to be a SurveyMonkey link. And in order to get the CEC, you need to do the SurveyMonkey. It's going to be 10 evaluation questions and then 10 post-test questions. Once you submit that, within 10 business days, you'll receive your certificate. Today we had 121 people sign up for this, so we're super excited about that, and thanks to Don again. And we're really hoping in the future, at least once a month, we can offer an education unit to the entire Catholic Charities Network. And how we want to do that is exactly what Don presented today, a program in the Catholic Charities Network that has best practices. And so I guess my plug is, if any of you out there want to present your program on a Friday afternoon for continuing education credit for the network, please reach out to me, Ben Wortham, bwortham@catholiccharitiesusa.org, and we'd love to hear from you. And so thank you, 121 of you, and thank you, Don. And we're going to say
Thank you
bye.
very much. Yep, thanks everybody.
Bye.